Hello, I'm Ronke Desalu from Lagos University Teaching Hospital in Lagos, Nigeria. And today I'll be talking about successes and challenges of cleft surgeries in a low and middle income country. This is my conflict of interest statement. I do a lot of work for Smile Train. Orofacial clefts are the third most common major congenital abnormality and the commonest craniofacial defect. The incidence is 1 in 500 births, or 0.5 to 1,000 in a hospital-based study. The care of cleft in the LMICs have been associated with several challenges, and we've had successes across fields with the patient, the parents, personnel, hospital, research, and country. There are various approaches to cleft management. We can have outreach programs when a group of doctors go into the rural area and perform surgeries and go back to the hospital. You can have cleft management through NGOs like Smile Train, Cleft, and others. The use of foreign collaborators and a local team like we have in my hospital. These different approaches have yielded results. In Liberia, in an outreach program, 377 procedures. In Sierra Leone, in another outreach program, 79 procedures. In South Nigeria, in 2 hospitals, 228 procedures. In rural Indonesia, 4 charity missions, 112 patients. And in Lagos, Nigeria, in my hospital, over 12 years, we've done 740 procedures. This is the Lagos University Teaching Hospital where I work. On the right, you'll find a typical theatre where I would be doing cleft surgeries. We've had a successful collaboration with Smile Train since 2007, and my hospital is one of the centres providing complete cleft care. Complete cleft care is provided by the surgical procedure and all the specialists that are involved in that, as well as pediatricians, pedodontists, speech therapists, and social workers, who all come together to form complete cleft care. We also developed a mentoring and body system of recruitment into the team. So the pioneer surgical staff encouraged junior colleagues to be part of the team. We had support by hospital management, and we formed a cleft clinic where our patients are seen weekly. We also had support by theatre management, and were able to obtain regular weekly operating lists for cleft surgeries, much to the envy of other surgeons. To date, we have performed 797 procedures and no mortality. We have what we call our in-house outreach programs, in which we pool patients together during the weekend and work throughout the weekend. We've had 7 such weekend programs, and we do 15 to 20 surgeries each weekend. On the right, you can see the graph of our surgical procedures. We had 2 dips in 2014 and 2016 due to healthcare workers' industrial action. When we go out for our outreach programs, we can go by boat, we can go by road, and we go out into the rural community and educate the mothers, recruit patients for surgery. And this is the typical day of our weekend surgeries. You can see the entire surgical team on the top picture, and then the rest of us trying to take a selfie. And the picture on the right shows some of the surgical team with the mothers and some of the babies waiting for procedures. The successes we've achieved. Well, we've had increased awareness, and so we're doing more cases. And the more cases we do, the better we become, and we have less complications encountered. This has led to increased skill and confidence of the local team. In addition, we've had 7 dissertations for fellowship awards around cleft, and we've established a post-fellowship surgical training in cleft with the West African College of Surgeons in conjunction with Smile Train. We have 48 publications in peer-reviewed journals, and one of our researchers is researching the genomics and genetics of cleft in Africa. With training, we developed the TeleCleft online lecture series in the West African College of Surgeons in conjunction with Smile Train, and that's ran over the COVID period and is still running. And some of it has been exported to Indonesia. We also have the Safe Anesthesia Delivers Smiles, a 3-day workshop which we've run in Nigeria and Senegal. The challenges are the same throughout the LMICs, one of which is late presentation. Why does this occur? Well, there's societal stigma. The parents will keep the child hidden, lack of money, lack of access to nearby hospitals, religious beliefs, and some of the patients actually do not know that this deformity can be corrected. Other challenges of cleft include fitness for surgery. When we pull the patients together and we find out that the day before surgery, maybe one is malnourished, so there's anemia, respiratory tract infection, or may need cardiology review, we need to keep our patients motivated so that they can come back for surgery. We lack difficult airway equipment, and this has made it difficult for us to intubate some of our syndromic children. With the brain drain going on across all the health workforce, we have reduced staff strength, and this has reduced the frequency of our operating lists. Hospital logistics include not having enough operating time and bed space. Sometimes we have no space to admit these patients, and we should consider doing some of the cases, especially the lip, as day cases. And of course, the stress of competing non-cleft surgeries. 40 to 6% of our patients are lost to follow-up after lip repair, and they don't come back for the palate. We have to chase them up to make them understand that the palate needs to be repaired before the child develops speech. What has been the effect of COVID-19 on cleft surgeries? Well, most surgeries restricted surgical services to cancer and emergency surgeries in the active phase of the disease. Later, when we started doing some elective cases, we were worried about the safety of the patients attending the clinic because they were coming from a very long way and they may need to come more than once. So we started doing WhatsApp assessments. We were also worried about the safety of the personnel attending to the patients. Did we test all patients? That wasn't feasible. There was also the increased cost of care because of PPEs for the personnel and filters for our machines. Also, the lack of adequate personnel due to isolation, due to positive contact or positive COVID tests. This is a paper on the impact of COVID-19 on elective cleft surgery in low and middle income countries between 2019 and 2020. The blue line indicates 2019 and the red line indicates 2020. And you can see that there was a drop in cases because of the COVID pandemic. In fact, 25,000 fewer cases were done in 2020 compared to 2019. In conclusion, LMICs have been able to provide cleft care to our patients. The development of local teams ensures skill transfers. There's still a need for more awareness because I'm sure that there are patients still out there. Staffing is still a problem and that has to be addressed. And it would be nice if we could develop a cleft anesthesia training program for things like difficult airway. These are my references, and I thank you for your attention.